So this is, I think, another great conceptual question. If a mutation was identified by liquid biopsy, in the case of this question, pleural fluid, should the same type of specimen be retested, or can the liquid biopsy now be blood? So I guess there's a few ways to interpret this, but one thing to say is that if you get a positive by any liquid testing, be it pleural fluid, and pleural fluid, by the way, can be a wonderful source as long as it's very cellular. It can be better than a solid chunk if it's very cellular with cancer cells. But at any rate, if you get a positive on blood or pleural fluid, you can believe that positive. Our caveats were about if you don't find it, that it's not necessarily negative. So if you get EGFR in pleural, if you get EGFR in blood, you're done, you have EGFR. So I like to, when describing this to my fellows, I sometimes say that there are two kinds of negatives that need to be distinguished from each other. One is the negative that I get an answer that I don't like. So I get back KRAS G12A, which at the moment is not actionable with an FDA-approved therapy. I'm sad about that. It's negative in the sense that I can't use it to help my patient, but I do have an answer. That's a believable early driver. I'm done. I don't need to push further. If liquid tells me there's KRAS G12A, I'm sad, but I'm not going to help my patient by putting sharp objects into them to get an answer, or asking people like Dr. Thompson to put sharp objects into them. On the other hand, if I don't get a clear driver back on a liquid specimen, that's when I have the negative that I need to push harder on. But the other way to interpret this question, I think, is whether if you get a positive by a modality such as pleural effusion or blood, and you're later needing a repeat biopsy, if you're necessarily set using that same kind of specimen, or whether in some cases you're going to need to go to tissue.
Yeah, I think that there's a couple of key points here. So blood, one of the reasons that we like blood biopsies is that whereas in a tissue biopsy, you're going at one site, and this is particularly relevant in the context of when you've already received a therapy and the cancer is starting to grow and you're trying to figure out what is driving resistance. When you biopsy a single site, you only know what's going on in that single site. A liquid biopsy is actually a pool of the DNA from all the metastatic sites. So it is as informative as kind of doing a liver biopsy and then doing a biopsy of this other spot in the liver and other things. So we actually think of it as somewhat more comprehensive than doing a single site biopsy. And to answer your second question, do you have to kind of go for the same site over and over? In a lot of papers that have been published studying kind of the evolution of resistance, people have done that. But in practical kind of clinical practice, what you should biopsy is what is going to be the highest yield. So if something is growing, that is what you should direct your biopsy at if you're trying to learn about what's causing resistance. And then we also try to biopsy what's the most accessible with the kind of the lowest risk.